Hi, this is Julie Levinsky. I am Associate Director of Digital for the Christopher and Dana Reeve Foundation, and I'd like to welcome you all to this month's live chat with Nurse Linda. I'd like to tell you a little bit about her. She's a leader and provider of rehabilitation nursing for over 40 years, and she is a frequent contributor to our brand new online community for those impacted and living with paralysis. And she is live in there answering questions every Wednesday evening. So, feel free to join our new community at community.christopherreeve.org, and I will put that link in the chat box as well. And now I'd like to turn it over to Linda. Hello, Linda.
Hi, Julie, and welcome everyone. It's nice to be here with you today. Thank you for joining us. I always look forward to these days when the webinar occurs because it's that time we really get to interact one-on-one. And as Julie mentioned, I'm also on Wednesday evenings. So if you get a chance, go ahead and if you have something you want to talk about or something you want to put out before the community, please go ahead and do that at any time. But on Wednesdays, I'm live in that as well. I just got back this last weekend from the Abilities Expo, which was quite a lovely opportunity to get to meet people. If you get a chance to go to any of the Abilities Expos, just please feel free to come because they are just most enjoyable, and I get to meet people and talk to people and find. And something just, I don't know, beeped at me, so I don't know what that's about. Anyway, there was something at the Abilities Expo that I hadn't seen before, and that was that an electronic nail clipper, which was very exciting. Now, there's been many of these out before, but this was the first one that I saw that looked like it would really work, and I had several people that I was hoping that would find that as exciting as I did. So it was just a little round machine, and you just put your finger right up to the place where you insert your fingernail, and boop, it clipped. The nail is collected in a little disposable drawer. You could empty it at any time. And so it really left enough room that you didn't get too down too close to the skin. And so that was really a nice thing to see. Now, I think the reason why I'm beeping is for some reason I have lost my video feed here on the computer. So I am just going to resubmit my name here and see if it's checking.
Oh, yeah, we can definitely hear you fine. We can definitely hear you fine, Linda. And
great.
So you can always join the meeting again, the web portion. So we can hear you fine.
Okay, and here now I can see the questions again. So that kind of threw me off for a minute. But okay, so at the Abilities Expo, there's a lot of fun things to do. There's a lot of people with different opportunities of products that you maybe have not seen before. And there's also things to do. They have a rock climbing wall there. At the LA Expo, they have a city bus that you can practice getting on and off without the pressure of the bus is ready to leave and there are people on the bus waiting to go. So at each expo, there's some different things to see. It's very exciting. Another thing that I went to this past month of February has been a very busy month, but this past month of February at the National Institutes of Health, there was a research conference. It was called 2020 Disrupting Research for Spinal Cord Injury. And what they had discovered was that there's so many things that are going on that are positive in the study of treatments and cures for spinal cord injury that they wanted to reset the agenda for research to speed it up and to match the progress that they've been making. What was unique about this particular conference was they had the top researchers from the United States there, people from different laboratories. It was kind of exciting to see, people who actually wrote the articles of research that we're reading about and all these exciting things that are going on. But also what was the best thing about the conference were people were there who have spinal cord injury, and they represented the community. And they were given opportunities and times to express their hopes, thoughts, dreams, concerns to the people who are actually performing the research. And they were very vocal, and they were very committed, and it was just wonderful to get that point of view. As we all know, one day is too many when you have a spinal cord injury, and they really let the researchers know to, get moving. And I think that when the researchers, a lot of them work in labs, many of them work in clinical trials with people, but a lot of research is done in the laboratory, and those researchers don't really see people with spinal cord injury. So when they see people and talk to people and find out what their real issues are, it really sets the bar for the researchers to get going and move forward, and you could feel the excitement building as people were working together. Something that didn't come up at the 2020, but it caused me to think about it, but it did come up at the Abilities Expo, were the issues of sham treatments. So if you go on the web, if you talk to people, there's always somebody who will give you a suggestion of this one isolated person who's discovered the cure for spinal cord injury. Now, mind you, nobody else is doing this, but you have to go to just this one person. Generally, you have to pay an exorbitant amount of money, and people will do that because there are not a lot of options, so people will participate in these types of studies. If there was something out there right now that was a cure that would make you better in a matter of hours, days, weeks, or even months, everybody would be knowing about it, and everybody would be doing it. So sometimes these people will have something that they've invented, a vitamin that you take, or they have some program that you should be in. But you always have to pay them a lot of money. Sometimes you have to go outside of the country to participate. And when researchers who are actively involved in this try to contact those researchers in other parts of the world, well, they don't really have any data to show. Or I know there was one study that was going on, and I was trying to get information about it, and they said, well, there's no real way to measure improvement in spinal cord injury. Well, yes, there is. There's the international scale, and in the United States we use the Asia scale, and European countries they use the Frankel scale. It's basically the same scale, but with just some tiny little tweaks of differences. But yes, there are scales to measure these things. So when people say, well, we can't really produce any evidence, or sometimes people will say, well, we have people that come in from different countries and they don't speak the same language, so we can't really ask them how they're improving. Well, you can measure it on these scales. So just be very mindful of these things. If there is a legitimate trial, it's generally advertised in the United States. If it has been approved by governing bodies, especially in the United States, the clinical trial will be listed on a website that I've talked about before, but I will provide it to you again. It's very simple. It's clinicaltrials, all one word, .gov, and that will give you access to any clinical trial in the United States that has been approved by an ethics board, that has been reviewed to make sure it's a legitimate trial. So be sure and look on that site. Then you can verify if that's a trial that's really going on. Generally, a clinical trial in the United States will not cost you any money. It's not billed to your insurance. There are funders, either the government or private funding. The Christopher and Dana Reeve Foundation funds clinical trials and supports many clinical trials along with other agencies. And so there's clearinghouses where people go through and they say, yes, this looks like something that is compliant with what's going on in the research as we know it. It's not something that's just kind of like, well, I think I'd like to try pie crust on the knees and see if that will help. So it's a very serious issue when you are volunteering to be in a clinical trial. We, of course, appreciate people who do. Sometimes they work out and sometimes they don't work out. But be sure you know what you're getting into. Sometimes people will want to inject something into your body. If we don't know what that substance is, that precludes you, that omits you from the next study that might come along that might be a legitimate study because you have some foreign substance in your body now from a study that hasn't been approved. So be very careful about this. There are a lot of clinical trials. If a clinical trial is going on but it's not in your area and you can't get to that area to participate, you can go still to that clinicaltrials.gov site, and there will be reports of what's going on in these legitimate studies. When a study has closed, there will be a report of what they found. So if there's some treatment, medication, some process, procedure that people think is legitimate and has been demonstrated to show some positive effects, it will be listed there. And then you can talk to your personal health care professional about would that help in your particular case. Because, of course, as we know, this spinal cord injury is a very complex process. You can have a spinal cord injury from trauma. You can have a spinal cord injury that's due to some medical problem that you might have, some issue that's going on. And will the treatments be the same? Maybe, and maybe not. So, depending on what you have going on in your body, you want to check with your health care provider to see if that's really going to be the right thing for you. So it's a good place to keep track of all that kind of stuff. So that's really good. Now, I noticed that we have a question in the question box about what kinds of tests should people be participating in their general health care. So I've been writing about this in the blog this past month, but let's just talk about this for a few minutes because there are some things that people with spinal cord injury need to do that are different from the general public, and then there's some things that you just need to do a little more often. So one of the first things I talked about was inoculations, and it's been flu season. We've just ended February. That's a month when flu, the second round of flu, comes on in the winter months. So a lot of people think October, November, December, now the flu's kind of subsiding, but it takes kind of a second big swing in February. So if you haven't gotten your flu shot for this year, feel free to go ahead and do that. Talk to your healthcare professional. Make sure it's right for you. There are some indications for some people who should not take flu shots. For example, people who have a diagnosis of Guillain-Barré, people who are allergic to eggs because they grow the vaccine in eggs. So you wouldn't want to take it if you have an allergy to that. But if you can take the flu shot, it's a good idea. Each year, the epidemiologists, people who study diseases, will look at what strains of flu, and there are literally thousands of strains of flu. They'll look and see which ones are the predominant ones, ones they think are really going to be very active in the winter months. And so they will develop flu vaccines particularly for those strains of flu. Now, fortunately, this year they were pretty much right on target, and they developed a flu vaccine that really worked well. Some years they're not so right on the target. Some years they think one strain's going to develop. They develop the vaccine, and that strain kind of dies out a bit and another strain takes over. But this year it's been right on target. Each time you have that flu shot, you're being inoculated against that particular strain of flu. So the next year, if that strain of flu comes up, you still have that inoculation in you. So it's kind of a building process as you get your flu shot every year. So that's something really important to do because getting the flu can be very detrimental to someone who has spinal cord injury because of the respiratory compromise. and the problems that come along with the flu. It can be very debilitating. You can get really very sick. And so taking your flu shot's really very important. Another shot that's important to have is the pneumonia shot, and they have this one down to pretty good science where you only have to take it once every 10 years, or they have some vaccines that you just take once and then poof, you're done with it. You've had it. So depending on what is best for you, again, check with your healthcare professional, but be sure and get your pneumonia injection, because you can have any kind of virus, bacteria in your body. You can get ill from all kinds of things, and as your body has become weakened due to a decreased immune system, sometimes pneumonia can creep right in. Now, breathing takes 3 sets of muscles. It takes the diaphragm working. That's the one that works the hardest to make you breathe. That pulls your lungs down so that air will come into your body. And then when the diaphragm relaxes, the lungs will contract back upward, and that pushes the air out of your body. So that's a very important muscle to have working. It can be affected by spinal cord injury depending on how high your level of injury is. The other muscles that are very important to your breathing are these little tiny muscles that are in between your ribs. They're called the intercostal muscles. They're tiny, but they're powerful. So they will make the ribs expand outwardly around the lungs. They pull the lungs outward. So the diaphragms pull the lungs down into your body, and these intercostal muscles pull your lungs, stretch your lungs out. So if you think of blowing up a balloon, it gets bigger and bigger in diameter. That's the way your lungs work with the intercostal muscles. And then a third set of muscles is also very important, and those are the abdominal muscles. And people often overlook those, and they think, well, my injury level's pretty low, so my breathing won't be affected because my lungs aren't affected. But if you don't have those abdominal muscles, they kind of are an extra little powerhouse to help the diaphragm pull the air in. So anybody who has a spinal cord injury has some muscles that are affected by the injury. It can be all of them, or maybe it's just the abdominals, or maybe it's just the abdominals and the intercostals. It can be any kind of combination of those 3 sets of muscles. So when you have pneumonia, you have collections of fluids and bacteria and virus in your lungs, and so that's compromising the oxygen that you're breathing in from moving in through the tiny little vesicles in your lungs into your bloodstream. So when you can't oxygenate your body well, the cells in your body are not being fed the energy that they need to keep moving. So pneumonia is very serious. If you have a spinal cord injury, or if you don't have a spinal cord injury, pneumonia is like one of the highest on the list of causes of death in the United States and in the world. Pneumonia is a very serious disease. So if you think about getting your inoculations, you want to be sure to have those so that you don't get those particular diseases, or if you do get them, they won't be as bad as if you didn't have the inoculations. If you can convince the people around you, your caretakers, people that you see every day, if you can get them inoculated as well, then you won't have so much exposure to these bacteria and viruses, and so that's helpful as well. Now, I know a lot of people have issues with inoculations, but this is one time to talk to your healthcare professional. If you have spinal cord injury, it affects your immune system, so fighting off some of these issues can be very difficult for you. Another inoculation that I would like people to think about is the shingles, because that lives inside our body. Shingles virus lives inside our body. It comes from chicken pox. So a lot of people will say, I never had chicken pox as a child, so I don't have the virus in my body. But once you have chicken pox, it's in your body. A lot of people have such a mild case of chicken pox that they don't even know that they had it. Now there is a chicken pox vaccine, but a lot of people are not inoculating their children, and so a lot of people think, well, chicken pox was eradicated because we don't see it much anymore. No, the chickenpox virus is still out there. It's still alive. People weren't getting it because they were inoculated against it. Now people are not having their children inoculated, and people are starting to get chickenpox. You'll see a lot on the news. There's a lot of outbreaks of measles right now, and they're in these pockets of areas where people haven't been inoculated. So those diseases are still out there, but shingles is one that lives within your nervous system. And exactly how that affects your spinal cord injury has not really been well documented, but it just seems to be logical sense that if you have a virus in your nervous system and you have a spinal cord injury, you don't want two things going on in your nervous system. One thing is enough, so try to avoid two things. Now, I did call the company and ask them specifically if people with spinal cord injury could have shingles inoculation, and they did say yes. But be sure and check with your personal physician. Maybe you have spinal cord injury from a medical cause, so maybe you don't want to have the shingles vaccination because there's some reason for that. So always double check and make sure you talk to your healthcare professional. You need to make a special effort to do this because a lot of these inoculations now are given by a pharmacist in a drugstore. So you might not be talking to your healthcare professional when you're offered this shingle shot. I know there was an original one that we got a while back, and now they've come out with an even better one. So I know when I go to my pharmacy, they're like, well, Linda, you need to have your new shingle shot. And so I know that I can have that, and so I will go ahead and do that. But most people should really check with their healthcare professional and make sure that they should have that before they are just like, oh, yes, well, I know for me, my insurance paid for it only through a certain window of time, so I was anxious to get it when insurance paid for it, when I wouldn't have to pay out of pocket for that. So don't feel pressured into these things. Just be sure you can give your healthcare professional a call and just make sure that that's okay. Now, some other things that you should do are some assessments that are done can be done for everybody, but in particular if you have a spinal cord injury, and that is a bone density test. Now, people who have a spinal cord injury need to have a bone density test assessment one time a year. If you go and you have the test done and it comes out normal, great. Then you don't need to do anything in particular. But if you find your bone density is sliding downhill, you can get on top of this quicker, earlier, faster. No matter what you have, if you treat it earlier, it's easier to treat than when something has gotten so far along. It always takes longer to treat. Like a pressure area, if you see a red spot, stay off of it and it will heal up faster than if you continue to put pressure on that area. The pressure injury gets worse. Eventually you have to have dressings because the area is open and that takes longer to heal. Or you might need surgery and that takes even longer to heal. So it's the same thing with bone density. If you are on top of this, then you can get it corrected without much problem. So the bone density test is a very easy test to have done. You go to a center where bone density tests are done. You need to wear clothes that don't have any metal in them, because when the bone density test is given to you, if you have like a zipper on your pants or a metal clip in your bra or snap buttons on your shirt or something that's metal, then the beam that's doing the bone density test will splay in that metal and they won't be able to get a reading there. So what happens in the bone density test is you go to a center, you don't wear any metal, you just lay on an exam table, so you'll want to talk to them ahead of time about how high the exam table is, if there's somebody who can help you transfer. Sometimes these tables don't go down low enough that you can do a transfer on your own. So get a little information about the table. Now what's nice about the bone density test is you don't take off your clothes, you just lay on this table. It does have a little bit of a foam cushion for you, but it's just about 2 inches of foam to kind of be there for comfort. It's not necessarily pressure dispersing. So that's what really spreads the pressure out from getting a pressure injury. So if you have a bone density test, they might do it in a couple of different phases. So be sure that you do pressure releases, roll your body, and there won't be a side rail, so you might need somebody to stand there so you don't flip off the little exam table. But be sure and do pressure releases when they're not doing the test. The test consists of like a wand that's attached to the exam table, and it goes over your body, about a foot above your body. That is really all there is to this test. You don't have to do anything. There's no needles. There's no sticks. You just lay there, and this wand rolls over your body. They will take density measurements in certain bones. So in the lumbar spine, which is that small curve in the back, and in your hip. And if the doctor orders it, they will also do your wrist. They do those particular areas because that's where people tend to fracture their bones if they have low bone density. So what is bone density? Well, your bones should have a certain amount of calcium in them. So they need minerals in the bones to remain strong, to hold your skeletal system together. When those minerals start to leach out of the bones, and this happens quite frequently with spinal cord injury, some of those minerals will start to gradually leach out of those bones. You get little tiny microscopic holes in your bones. When you have just a few of this, if your bone density is just a little low, they call it osteopenia, which means you're starting to have low bone density, but it's not really too bad yet. When the holes get bigger and there's a lot more of them, you have osteoporosis, which means you have a really low bone density and your risk of fracture is very high. Now, sometimes people think standing is the reason why, or lack of standing is the reason why people have low bone density, and it is one of the reasons. So if you're sitting and not standing on your bones, the minerals tend to slip out of the bones. But there are other reasons as well. So you could have a genetic history. If you look at your family and people had low bone density, that could, you're genetically predisposed to that. So that now you have two risk factors if you have spinal cord injury and you have low bone density. Females tend to have bone density problems more than males. Although males get bone density loss as well, the reason why females are so noted so much more, and you'll see women with, kind of this humped over back, that's from having low bone density in their spine, and their spine simply can't hold up the weight of their upper body. Same thing happens with a spinal cord injury. If you have a higher level of injury, you have to hold up your upper part of your body with the muscles that you have accessible. So there are a variety of reasons why you can have bone density. One is if you have a spinal cord injury, and then there are a variety of reasons otherwise as well. So be sure to have your bone density tested. Now, the reporting is very peculiar because it usually is reported in numbers from like 2 to -1. That's a normal bone density. It's done by averages, so that the reporting system is not as you would normally think it would be. Sometimes people think, well, if I have a -1, how could I have a normal bone density? But that's still in the normal range. So I was just talking to somebody, and they went for the bone density test. How was it? Oh, they said it was normal. So, okay, they went on about their way. They didn't go back for 2 years later to have the bone density repeated. And when they did, they found out that they were almost in osteoporosis. And when they found out and they asked, the report was that they had 2 years ago this -1, which is a normal report, but it's the last number before you start having low bone density. So that would have been the time to start treatment for the bone density because it was getting so low. And it was on a downhill slide. So they thought they were doing just great because they were told it was normal. So find out what your number is and where it fits in the scale. Very important to ask about. Once you have problems with your bone density, there's medications to treating it. Some people use exercise and standing. I don't know if it's so much standing or if it's actually the muscle pulling on the bone when you move your limb. So doing range of motion exercises can help because that activates your muscles, and your muscles are attached to your bones by tendons, and that seems to strengthen the bones. Sometimes standing is just not enough for improving your bone density. Sometimes you need medication. So bone density tests for people with spinal cord injury should be done every year as opposed to every other year, because you want to get on top of it sooner. If you do have a fracture in your bone and you have a low bone density, it's very hard to repair that fracture. I have another person that I speak with quite frequently who is a gentleman that had a low bone density and didn't really realize it again. And he fell, he tripped, and he fell. He was an ambulatory, and he tripped, but he has spinal cord injury, and he tripped and he fell on a sidewalk and fractured his lumbar spine, that little curve in his back where, that's where a lot of that, where a lot of the fractures occur. Also, in your hip or in your femur, a lot of the fractures will occur there. If you have so if you have normal bone and you have a fracture, they'll put in a little plate and some screws and they'll fix that fracture so you're back in business. If you have a low bone density, they can't do that because there's no place to put the screws in because the bones are all this real thin, powdery kind of bone. So it's a very dangerous situation to be in if you get that low bone density. So you want to stay on top of that and have that every year. Now, if you go 10 years and you're thinking, well, every year I go for this test and it's normal, I think I'll skip a year. Well, eventually low bone density is going to come, and if you skip a year, it could have come that year. So be sure and just have it done every year. If it's normal, great. You move on with your life. Keep doing what you're doing. But if it starts going down and it's a little bit low from the last year, you can get on top of it by exercising your legs. If you need medication, take that medication. You can get on top of it before it gets too bad, and then it takes a lot longer to fix. Another test I want to talk about, and I really want to get to the questions as well, is urodynamic testing. But this is something that people should have done yearly. Some people will have it done more than once a year. Some people might not need it every year. But the bladder, again, it's testing of bladder function, and the bladder is one of those things. It's like your bones. You can have this test done every year for years and years, and it's normal. Great. Keep doing what you're doing. All of a sudden, after years of being normal, something happens in your body. We get older. Pressures change in our bladder for whatever reason. It can happen to anyone, spinal cord injury or not spinal cord injury. But you're at higher risk if you have a spinal cord injury. So have your urodynamic testing. It's more invasive. You're in a room where your lower half of your body is exposed, so you don't have clothes on. You're sitting on an exam table. Again, you're going to need to talk to the staff to make sure the room is warmed for you, so you don't get chilled because you're half naked sitting there. It can be kind of a rude awakening to be half naked in front of a doctor or assistant and, people around. Most people with spinal cord injury have kind of become used to that, but some people, it's your private areas exposed. They will put fluid into your bladder through a special catheter and measure the pressure inside your bladder, the pressure around your bladder and your abdomen, and the pressure of your sphincters to make sure everything's working in order. Again, the bladder is one of the things that can turn in your body on a dime. So you want to make sure you have everything in working order. And again, there's medications that can help correct if the sphincter's closing when the bladder's trying to squeeze, and then the pressure's building in your bladder, which can cause urine to go back up in your kidneys. So this is a very critical test to have at least one time a year. So I highly recommend those. But let's get to some of these questions, because our first one is a really good question. It's a gentleman from Pakistan who's 71 who had a spinal tumor and became paralyzed from D2 to D10. Now, in other countries, D is used. In our country, T is used, so this is a thoracic injury. He has a suprapubic catheter, so he's got his urine managed. So he's keeping his bladder drained at all times, but he's having trouble passing stool, and he's taking a laxative. And so he needs some helpers, and he's using diapers. So what he needs is, and Zafar, what you need is what we call a bowel program. So just expecting the bowel to evacuate or using laxatives is very unpredictable, as you have discovered. And so you don't know when that stool is going to come out or how it's going to work or if you're going to have diarrhea. Using laxatives is kind of a higher level of treatment. If anyone, spinal cord injury or not, continues to use laxative, you kind of your body becomes used to that, and your bowel won't work unless it has a laxative. So because you're taking over the control of that bowel movement through laxatives, your bowel's not working in its natural way. Even after spinal cord injury, your bowel will propel stool along it. It's the expulsion that's the problem. The propelling the stool through the bowel can be slowed, but it's getting the stool out that's the problem. So you can get, in Pakistan, you can get the Ducalox suppository. Insert one into the rectum with a lubrication on it and a glove finger that's lubricated. And you can go to the Christopher and Dana Reeve Foundation, and they have instructions for how to do this. You can go into my blogs. There's instructions on how to give the suppository. And put the suppository in as far as your finger can reach, and be sure that you put it up against the wall of the bowel. And then after about 10 minutes, if you have not had a bowel movement, do digital stimulation to, again, a gloved, lubricated finger, reaching in as far as you can. There's an outer sphincter that you'll pass right when you enter the rectum, and then higher up there's an inner sphincter. Very gently massage that inner sphincter, and you might feel it. You might feel it relax, but that helps. The Ducalox suppository will activate the bowel to bring the stool down, not traveling throughout the whole bowel, but it will activate the lower bowel to bring the stool down, and then do digital stimulation a couple of times. If you can sit up on a commode or a toilet, that will help bring the stool out of your body, because gravity always helps bring the stool out. And try that every day, and then eventually you can get on every other day. But to switch on to this is going to be a little bit of a challenge because you've been so used to the laxatives. Stop the laxative, switch over to the Ducalox suppository. Now at 71, the Ducalox might be a little bit too strong for your bowel. I don't think that it will, but it could possibly, in which case you might want to try a glycerin suppository. So check with your healthcare professional, make sure this is okay. You might need to add some more fiber to your diet by eating foods that are high in roughage, or you might need to add some fiber to your diet through Metamucil or some of these other products that you can take in water or in a wafer or cookie to add more fiber to your diet. And that will help clear up the bowel program. And so you'll know when you're going to have a bowel, but you need to do it at the same time every day. You'll know when your bowel's going to empty, and you can get away from those diapering, which is keeping that stool on your skin, which is a real risk for pressure injury. So you can look that up on our website there and try to switch over to a bowel program that causes your bowel to work in a more natural fashion. And that will help with some of those things. So I hope that helps answer your question in a very quick manner there, but you can get more information about that online. So here's a question about health maintenance, checking your cholesterol, looking at your A1C, which is a blood test for diabetes, looking at your weight, your general health, doing the things, getting the inoculations, and doing the bone density and urodynamic testing yearly. And then the other thing that's on here, which seems kind of not too serious, but blood pressure. Knowing what your average blood pressure is very important. People who have spinal cord injury tend to have lower blood pressures than people who do not have spinal cord injury. So if you become ill and you know that your average blood pressure is, say, 100/70, and you become ill and your blood pressure goes up to 120/80, you go to the hospital or the emergency room, they take your blood pressure, oh, it's 120/80, it's normal. It's normal in the general population, but that might not be your normal. So knowing what your normal of blood pressure is going to be very important, especially if you have autonomic dysreflexia. Your blood pressure could go up to 130/90, and they wouldn't be in too much of a panic about that in the general population. But if your average blood pressure is 80/50, that's gone up extremely high, and your vascular system is not used to accommodating that kind of blood pressure anymore. So knowing what your average blood pressure is going to be very important for everyone, just to know in terms of health, because blood pressures in this group population really run a lot lower, and as time goes by, they get even lower. Check your heart, check your pulse, and look for little flutters in your pulse, atrial fibrillation. When your heart is beating out of sync, it feels like little butterflies right up in your chest area. Sometimes people don't feel that because they don't feel that part of their body, but they might be having some heart problems that could be from irregular heartbeats. So every once in a while, check your pulse. You don't have to do this every day even. Just periodically at random different times a day, check your pulse and see how it's doing. Make sure your heart's beating in a good, satisfactory way. If you have a lot of fibrillations and your irregular heartbeats, that can also lead to blood clots. So be sure and check your pulse to make sure, because if you're not moving your legs much, and if you're not doing passive range of motion or having it done to you, sometimes that blood can pool in there when those fibrillations are going in your heart, or the irregular heartbeat is activated and you're not having that regular beat. Sometimes the blood is pooling, which can cause blood clots in your legs. Check and, look at your body, check your skin, look and see if you're having edema, look and see if you have any changes in your body anywhere, red spots, warts or moles changing, all the regular things that you need to do to monitor your skin. If you're not sure if you have a little spots in place, or if you can't see your backside and you have a cell phone, take a picture. Get a mirror and have a good look at your backside. Maybe somebody is doing your care and they're checking your back or your bottom, but it's up to you. It's your body, so know what that looks like. Take a picture. If there's a red spot, take a picture and see if it's resolving over the next few hours, or see how it's progressing. So taking a photograph on your cell phone that won't go anywhere. It's your personal cell phone, so it's not going out to the world. But take a picture, and you can see if you want to take a picture of the back of your head or your ear or someplace where you can't see well. Take a picture if anything looks suspicious, and then you can always show the doctor, this is what it looked like 2 weeks ago. This is what it looks like today. This is why I'm here. So having that information for your doctor will be very beneficial. The next question, and I noticed there's several questions about neuropathic pain, neuropathy. And so in this particular one, and I know there's another question that's coming up about which is probably neuropathic pain. The next one is about neuropathic pain as well. So in this first one, this gentleman had a T12 burst fracture 5 years ago, and they were put on oxycodone. Okay, red alert. If you listen to TV, we know that oxycodone is very addictive. Oxycodone is also not a treatment particularly for neuropathic pain. It's a treatment for pain, but nerve pain, neuropathic pain, is a whole different animal. So be sure and talk to your doctor about taking some of the medications. for pain. So this gentleman had oxycodone. He's been taken off that. Now, oxycodone has to be weaned off. You cannot just stop that. Any of the nerve pain medications, you cannot just stop them. Sometimes people will say, well, I'm just going to stop it and I'll just tough it out. No. Once you've been on these medications, they're chemically changing your body, which is how they control the pain. So once you've had that chemical change in your body, you can't tough it out. The change is there, and if you just stop these drugs cold turkey, you go into a withdrawal, but it's very hard to get that pain under control again. So be sure and follow the tapering or the weaning schedule that your healthcare professional provides for you. But now, so oxycodone dulls the brain so that if you have pain anywhere in your body, you just don't notice it so much. But nerve pain, as I said, is just a little bit different. So there are only a few drugs that treat nerve pain. So the lower level drugs are drugs that treat depression, antidepressant, and drugs that treat seizures, anti-epileptics. Now you say, but I don't have depression or I don't have seizures. You don't take enough of these drugs to even treat depression or seizures. So like if you had a depression or a seizure, you might take 150 milligrams or 100 milligrams. To treat neuropathic pain, you only take about 10 milligrams. And you can go up a little bit on that. Sometimes people start out at 5 milligrams. And so you just take it for really what they found out with these antidepressant and anti-seizure drugs is a side effect is that it helps neuropathic pain. And so you just take a little bit of the drug, and that seems to help people with neuropathic pain. There are two drugs that are specifically designed to treat nerve pain, and that is gabapentin and pregabalin. They're under the trade names of Neurontin and Lyrica. So those are the drugs that are specifically designed to treat nerve pain. Now, if you take any of these drugs, the antidepressant, the anti-epileptic, or the nerve drugs, it's not like you will take these drugs and that afternoon you'll be pain-free. It takes about 6 weeks. That is a long time when you have pain. It takes about 6 weeks to build up enough of these drugs in your bloodstream to affect the pain and really get it under control. It's also, pain is so subjective to everybody. You and I could have the exact same pain, but we could report it differently. Some people are very stoic and they say, oh, it's just a little pain, and somebody else could have pain and say, oh my gosh, no, it's on a scale of 1 to 10, it's a 200. So figuring out exactly how to treat people's pain is a little bit of the art of healthcare and not so much the science. So people have a general good idea because there's a lot of research on these drugs. They know how much to start you with, but it will take several weeks for you to start noticing, maybe a couple of weeks before you even notice the kind of the edges off of it. And then if you do take those drugs, the antidepressants, the anti-seizure medications or the nerve pain medications, once you're on them, you can't say, oh, it's not working, I'm not taking it anymore. Remember, it's altering the way the chemicals in your body are working. So if you decide you don't want to take them, again, you have to taper off these drugs. Now, there are some things that you can do, and I noticed in the next one, there's a gentleman who's having some pain. When he gets into bed, it goes up. So some of the things that you can do to help that is to do some range of motion exercises. People always overlook this because, people want the big bullet for the pain, but if you gently move the legs periodically, now, you have to be realistic. You can't, get up in the night and be range of motioning every 15 minutes. But if you can stretch out the legs, which stretches out the muscles, which keeps those muscles from tightening up, so it's stretching the nerves, that will help a lot with the nerve pain as well. If after you've tried the drugs and you've given them, the good try for several months and maybe even a year, and it's still not working out for you, then you might want to go on to something like a nerve stimulator that blocks the nerve messages. Sometimes if people are having nerve pain because they're having such spasticity and that's triggering the nerve pain, sometimes they'll get baclofen injections for the spasticity, which will relax the muscle. so that it's not tightening so much. And so, you just keep working up the hierarchy. But for most people, eventually they will find the code with the nerve pain medication. Now, sometimes you'll be on that nerve pain medication and it might be working well, and then after 6 months or a year or 2 years, it's not working so well anymore. You might need to go up on those nerve pain medications periodically through your lifetime. Neuropathic pain is always changing, and in reality, sometimes it goes away. Over years, sometimes for some people, the neuropathic pain just resolves on its own. Then you'd want to start tapering off the medications to see if you can get off of them. So sometimes people will be taking Neurontin or Lyrica for a couple of years. Maybe they've been taking it for 5 years. They say, hey, I'd like to try it without this. Again, talk to your doctor. Get a lower dose and see how it goes. And if you can tolerate a lower dose and even lower dose, maybe eventually you'd even be able to get off that pain medication. Neuropathic pain changes. It's not the same this month as it will be next month. So it's really a moving target, so it can be quite tricky to get that neuropathic pain taken care of. So the next one is a really complex question here. It's about a woman writes in about her daughter who's had a C5-6 spinal cord injury for 19 months. She's having issues with involuntary shivering of her arms, and it's painful, and she relates it to being cold, but she's not cold. So it could be a problem with the autonomic nervous system, which is responding to there's something wrong in the body. And because of the spinal cord injury, that message is not getting to the brain for interpretation. So mom's doing a good job. She's keeping her daughter warm, which is helping that autonomic nervous system stay in check. Another thing that it could be would be to check the blood pressure and see if there's some kind of autonomic dysreflexia that's going on. Some people have autonomic dysreflexia and they get the pounding headache. Everybody learns about the pounding headache. But there are other symptoms too, and shivering can be one of them, even below the spinal cord injury. Goosebumps, a feeling of dread, visual problems. There's a whole list of symptoms. There's an autonomic dysreflexia pocket card that you can take to your healthcare professional if they're not quite so familiar with it. It's kind of a nice thing to do because it's very low key. It's a trifold, but it folds up to a size of a $1 bill, so you can keep it in your wallet. It has a place on the back where you keep your average blood pressure. So check the blood pressure when the shivering happens. See if it's varying, if it's going up from the normal blood pressure. To treat autonomic dysreflexia, you take advantage of another complication of spinal cord injury, and that's at low blood pressure. So if you sit your daughter up very abruptly, the blood pressure drops, and that might help with the shivering. If that makes the shivering go away, it's autonomic dysreflexia. It will help treat it. But you want to talk to your doctor because you'll need to find out what the source is. It could be, most generally, it's a bladder problem. The catheter's kinked or it needs to be catheterization. Sometimes it's impacted bowel. Sometimes with the young kids, it's too tight a clothes. Everybody wants the skinny jeans, and you put them on, and then they sit up and they're cutting into the waist or they're digging into the groin. Sometimes it's shoes that are too tight. Sometimes it's a wrinkle that you're sitting on. Sometimes people get autonomic. They're so sensitive to it, they get autonomic dysreflexia just from the current of the heater or the air conditioner blowing across them, across their skin, kind of across the little tiny hairs on the arms, and people will get that triggered. So there is medication for that if you would need that sort of thing. So it's probably something askew in the autonomic nervous system. Now, people who have spinal cord injury need to have the temperature in their house regulated for their comfort. So if it's really cold outside, even though you're in your home and you're sitting close to the window where it might be cooler than if you're sitting in the center of the house more. Sometimes those temperature variations can trigger these kind of things. If you're in a room with a lot of windows or that's a little bit colder, you need to keep that temperature not too hot and not too cold, but just keep it regulated. Going in and out of the house in the cold weather can trigger these episodes as well. So figuring out about that autonomic dysreflexia and getting one of those pocket cards will help you. If you take it to the physician, you can say, this is what we've been learning about. Inside this pocket card, there's information to the physician, and there's articles that are the gold standard treatment of autonomic dysreflexia that your physician can choose to read if they want more information. So it's very helpful because a lot of people are out in the world, they take care of people with spinal cord injury, but maybe they don't see a lot of them, or the problems are different depending on which patient they're treating. And so sometimes people don't see autonomic dysreflexia and they're just not that familiar with it. So that would be the best place to start to see how you could correct that problem. Here's a person the next one is a person that's diagnosed with osteoporosis and they're having side effects. Be sure and talk to your healthcare professional if you're having side effects with any medication. It says, do these side effects go away? Well, that's kind of, some people they do and some people they don't. I know for some medications to treat osteoporosis, you need to sit bolt upright after you take the medication for an hour till it clears out of the stomach, because it gives a lot of GI distress sometimes. That might not be the medication for you. There are other medications to improve bone density. Also, maybe you want to try one of the other types of medications. This is a real popular one, but maybe it's just not the one for you. The other thing to talk about is if you can get any kind of therapy to help move your legs, if you can get a standing frame with a glider. So everybody should have a standing frame so that you can put weight through your body. It's a chair that you sit on. There's some straps that go around your knees and around your hips, around your chest if you have a higher level injury. There's a pump that can be pumped up, and so eventually the chair will push you up into a standing position, but you're supported so that at your joints so you don't fall over. You have to monitor your new areas of pressure injuries where these straps are holding you in, and then put some weight on your legs. If you can get the ones that have the gliders, kind of like you see the treadmills with the arm pieces that glide, so if you can move your arms, they'll in return move your legs. You can, if you're not sure how to use this equipment or what piece of equipment is right, most insurance companies allow, even the Medicaids will allow for 2 weeks of mobility training. You can use that 2 weeks to try out the different standing frames to see. And again, moving those legs, if you can move your legs, if you can get somebody else to move your legs and your arms, if you can do it independently but go through the whole range of motion at each joint, do it several times a day. That gets that tendon pulling on the bone, and that seems to help a lot. So, check with, you shouldn't have to have those side effects. So check with your physician, see if there's something else. You will need to take something if you have osteoporosis to correct it. You'll need to take some kind of medication. But there's also these other things you can do with activity that will help as well. So be sure and look at a variety of things. This is a very interesting question. So this person's been in a wheelchair for just 2 years and their toes have started to curl under. Is there anything I can do to reverse this or stop it from getting worse? Yes, there is. So if they're starting to curl under, it could be that you have some contractures and you will need to have a therapist's help in getting those stretched out. If you can still put your toes through the full range of motion without much effort, you don't want to break your toes, but if you can do that, then you can range those toes out and stretch them out. That will help make that muscle stretch out longer. So in our bodies, if we don't use a part of our body, our bodies will start to curl towards the core of our body. So now it sounds like the toes are curling down, which seems like they're curling away from you, but actually they're curling into the underside of the foot, which the leg would then pull up to the abdomen, so you see it's really curling towards the inside of the body. Anyway, and then be sure that you're wearing, once you get your toes ranged out, be sure that you're wearing shoes that will keep your feet in position. So I see a lot of people with spinal cord injury, and they don't wear shoes because their feet are swollen, or they'll, what I usually hear, especially from younger people, is, oh, well, I don't get cold, I don't feel it, so it doesn't bother me. Yes, weather still affects you, whether you feel it or not, because your body's still working. It's just that you're not getting the message to control it yourself. But your body still feels it's cold, and your toes are curling. So some people will sleep when they start having problems with their toes or their ankles. Some people will sleep with like a tennis shoe on, a high-top tennis shoe, to hold their feet in place at night so that their toes are supported and their ankles are supported. There are moon boots that you can get to help protect your ankles from pressure injury and will also support your ankles, but the toes are left open. So if you can wear any kind of support to keep the toes in position. But before you get all that support for your toes, you need to have them stretched out. So talk to your healthcare professional about, do you need to see a therapist? Sometimes they will need to put a cast on your leg to help stretch out those muscles. Sometimes the doctor will give you a little Botox injection to help stretch out those muscles. But you'll need to keep moving them and keep all your joints active, using some movement to keep them stretched out. So it's from either the sheets laying on top of your toes, which is pushing them down and under, and the muscles have become weak and the weight of the sheet is actually constricting your toes, or it's not from wiggling your toes, doing your activity of daily motion, doing your exercises. So yes, this can be reversed, and you need to get it stopped now because, again, stopping it is easier now than it would be later and having multiple surgeries to release the contractures. So be sure and talk to your doctor right away about what particular things that you should be doing for that. And then there's another question here about having some sharp pain in this lady's having sharp pain in her neck. It's either neuropathic pain or she's quadriplegic, so it's in her neck and shoulders. Sometimes those pains in the neck and shoulders, if it's above the level of injury, those muscles are being overworked to hold up the head. And the head's a big melon to be held up by this little tiny, really golf tee structure, the neck. So that's a lot of weight that the neck has to hold up. If you're doing that only using those few muscles in your neck and shoulders and not, our muscles all work together, the trunk and supported by the abdomen, so those muscles are probably being overworked, so she maybe needs some more support for her head. Talk to the therapist about more support. It could be neuropathic pain, or it could be in the neck and shoulders. It could be there's a bunch of nerves that come out at the neck. They come out of the spinal cord and through the vertebrae at the neck, and they go into the shoulders and the brachial plexus. Sometimes if somebody's had a high-level injury, that plexus of nerve is kind of like a bowl of spaghetti of nerves, if you can imagine. It's just a bunch of nerves that are all wound up there together in the shoulder, and sometimes that can be injured or overstretched if you have a high-level spinal cord injury, because it's those nerves from the neck that are in that brachial plexus. So you might want to talk to the doctor about if those nerves were overstretched in the injury, if she needs more support, or if it's neuropathic pain, and maybe you would want some treatment like that for that. So we are now at the top of the hour. I've gone on a little bit too long. So if you have anything you want to talk about more, I didn't get to everyone's questions, remember that I am on tonight, or you can go into the communities and you can tag me, and your question will come straight to me. So just, there's lots of ways to get a hold of me through it. So if I didn't answer your question directly, please feel free to write into the communities, because your question is going to be a question that a bunch of other people are going to want to know about as well. People have very similar questions, very similar issues. So be sure and write those in, because you'll be helping yourself, but probably somebody else who's maybe a little too shy to ask. So thank you for letting me spend this time with you today. I look forward to next month, and I hope to see you on the communities. Talk to you soon.
This concludes today's call. Thank you for your participation. You may now disconnect.